intermediate acting here. Examples are lidocaine, mepivacaine, prilocaine, and the long acting are tetracaine, bupivacaine, etidocaine, ropivacaine. Now we briefly discuss about the pharmacokinetics of local anesthetics. These local anesthetics are weak bases. And when they are given by topical application or by infiltration by injection, they are readily absorbed by the blood. So the blood flow of the tissue is very important for the duration of action of a local anesthetic. So these drugs are weak bases and they are available as soluble stable salts. And the pKa of these local anesthetics are between 8 and 9. Most of the local anesthetics have pKa of 8 and 9. The pKa is that pH at which the non-ionized and the ionized form of the local anesthetic are equal. So whenever the pK is more close to the physiologic pH, the physiologic pH, you know that is 7.4. The onset of action, the more drug is available as non-ionized form, in the uncharged form, so the onset of action is more rapid. But once inside the tissues, the increased blood flow, and all local anesthetics, they are vasodilators except cocaine. So the increased blood flow wash out the drug, so the duration of action is decreased. For that purpose, a vasoconstrictor could be added with a local anesthetic. We study later. The factors which can modify the systemic absorption, of course, the dosage is important, and the physiochemical properties of the drug, and the site of injection, that is intercostal, there is more absorption as compared to tendon, because the tendon, the blood flow is very low. And local tissue blood flow, if the blood flow is rapid, the drug is washed out. And if a vasoconstrictor is added, the drug stayed in the tissues and the duration of action and the quality of block is much better. Usually a sympathomimetic alpha agonist is used for a vasoconstrictor, and epinephrine is most commonly used. We are commonly using xylocaine, lidocaine, commonly known as xylocaine, in our operation theaters with a combination of epinephrine. And with the addition of epinephrine, not only the duration of action is prolonged, but the quality of block is also improved. Advantages of this local anesthetics I have already described. The metabolism and excretion is important of local anesthetics. And it could be asked in SCQ or MCQ. The metabolism of esters and amides are different. The ester type anesthetics, they are hydrolyzed by plasma cholinesterases, known as pseudocholinesterase. These metabolites, these are water soluble and they are excreted in the urine. While the amides, they are hydrolyzed in the liver. In the liver, there is cytochrome enzyme, P450 microsomal enzymes, which hydrolyzed these amide local anesthetics. And of course, if the liver is not functioning properly, especially in very old age or in a liver disease like liver cirrhosis or hepatic failure, the metabolism of these amide local anesthetics are decreased, so there is more possibility of toxicity of amide anesthetics. Similarly, if the blood flow of liver is compromised, which happened in congestive cardiac liver, the hydrolysis of this amide local anesthetics are inhibited. So there is more possibility of toxicity. So these, the condition of the liver should be considered whenever you are giving amide local anesthetic to a patient, especially in old age patients, very young patients like neonates, and with liver cirrhosis, with congestive cardiac failure, acute hepatitis, or hepatic failure. Now we come to the pharmacodynamics. The most important question usually asked is the mechanism of action of local anesthetics. It has been postulated. The theory is the local anesthetic block voltage-gated sodium channels present in the excitable cell membranes, like axons and other excitable membranes present in heart or the brain or the other tissues. These sodium channels, these are 4 hexamers around a center pore. You can see the diagram here. These are the sodium channels present in the axon membrane, epineurium. And these local anesthetics, they block these sodium channels. This is the mechanism of action. But before that, we should understand action potential. If you recall from your physiology study, the resting membrane potential is maintained in a cell membrane, especially the axon, by the active transport and by the passive diffusion of ions, especially the sodium and the potassium ions. And this resting membrane potential is minus 70 millivolt. You know, the sodium is in higher gradient concentration outside of the cell, and inside the cell, the potassium is in higher concentration. And inside the cell, the negatively charged proteins produce this resting membrane potential, which is minus 70 millivolt. Whenever any chemical, mechanical, or electrical impulse is given, there is a sodium influx causing depolarization from minus 70 millivolt to minus 55 millivolt. This minus 55 millivolt is the threshold of excitable tissues, the axons. When this minus 55 millivolt threshold is reached, there is a sudden, these voltage gated channels, they open up, and there is a sudden and spontaneous influx of sodium ions causing depolarization of the nerve membrane, causing from minus 55 millivolt to plus 35 millivolt. This is called depolarization, and this depolarization is propagated along the nerve axon to the spinal cord, and from the spinal cord to the thalamus, and from thalamus to the sensory cortex. This is called action potential. Most local anesthetics, they bind to the sodium channels, preventing this sudden and spontaneous influx of sodium ions, thus preventing this depolarization of the axon. So no action potential is produced, and when there is no action potential, there is no pain perception. So this is the mechanism of action. And these sodium channels which are present in the epineurium, Besides that, there are sodium potassium active transport. This sodium potassium transport, it restore the resting membrane potential of the epineurium. The pKa is very important for the onset of action of these local anesthetics. The pKa is the pH at which the non-ionized and the ionized form of the drug is equal. For penetration into the cell membrane, non-ionized form is required. Uncharged drug can only penetrate the lipid membrane of axon. Once inside the cell, this non-ionized form is charged, it becomes positively charged, and then it binds with the receptor of voltage-gated sodium channel and block it. So this is the basic mechanism of action that local anesthetic block voltage-gated sodium channel in the axonal membrane, preventing this spontaneous and sudden influx of sodium, which is required for neuronal conduction or action potential. This is a diagram of an axon, and you can see these sodium channels are present along the axon. So when no action potential is produced, there is no perception of pain and other sensations. This propagation of action potential, this depends on different factors. It depends on the kind of nerves. The myelinated nerves are more rapidly blocked. Similarly, the fiber diameter and the myelination is important. Firing frequency, the pain fibers are firing more rapidly, so they are blocked earlier than other sensory modalities. On the basis of their diameter of a nerve fiber, the fibers are divided into, categorized as type A, type B, type C fibers. The type A fibers are largest fibers, and they usually conduct pressure and motor sensations. And the type B fibers are moderate in size, and they preganglionic autonomic impulses and pain sensations. And the type C, they transmit pain and temperature sensation. These local anesthetics, they block type A delta, type B, and C fibers. So the pain, temperature, and light touch is blocked, and there is autonomic blockage as well. In the earlier, I have mentioned that these local anesthetics block transiently the sensory, which contain pain and temperature, and light touch, motor block, and the autonomic block. When local anesthetic is given or infiltrated locally, the temperature sensation gone first, and then pain, then light touch, then deep pressure, at the last motor control. But when the local anesthetic effect is waving off, these sensations, they come in this opposite manner. First of all, the motor function comes, then deep pressure comes, then pain comes, and then the temperature sensation come back. Therefore, patients who have blocked pain sensation still feel present and have mobility because of the unblocked type A fibers. If a local surgery is being performed, the patient may feel pressure, but there is no pain. A few words about now clinical pharmacology, which is important. These local anesthetics not only used in for giving local anesthesia, but they can also be used for control of neuropathic pains anywhere in the body. They can be injected into the ganglion, or they can be used as anti-arrhythmic drugs, and especially this lignocaine, known as lidocaine. It can be used. It's a membrane stabilizing drug, and it decreases the automaticity of the heart uh, nerves. So the ectopics may be controlled by giving lidocaine in low doses. So the use of these local anesthetics are three-dimensional: for local anesthesia, for surgery, for controlling neuropathic pains, and anti-arrhythmic for controlling arrhythmias, especially ectopics. Local anesthetics can be used topically on skin or in the mucous membranes. And, uh, and the second, most commonly, these are used as infiltrating locally by injection into the skin, into the dermis, and it can also be used in subarachnoid space. They can be injected directly into the CSF, which is called spinal anesthesia, and they may also be used in the epidural space. And they can also be used IV for intravenous renal anesthesia, and this is called Bayer block. This topical use of these local anesthetics and their local infiltration, usually they are used for abrasions, burns, wound margins, and the mucous membrane. This is a topical application for abrasions, burns, wound margins, the sports injuries, and the pharyngeal surgery, nasal surgery, tracheal, urethral, esophageal manipulation like gastroscopies and ureteroscopies. You may use this topical anesthesia. These surface anesthetics, they're usually available as sprays, solutions, creams, gels. And usually they are used for eye surgery, for topical use. And cocaine was the first local anesthetic which was used by an ophthalmologist for an eye surgery in 1884. This was the first local anesthetic ever used for surgical procedure. For nose, this cocaine and the procaine can be used because cocaine is a local vasoconstrictor. So it is very effective for nasal surgery because the nose is very have a good blood supply. So it acts as a vasoconstrictor as well as for anesthetic purpose. For for this purpose, other local anesthetics can also be used. This lidocaine with the combination of epinephrine, lidocaine, bupivacaine, tetracaine, benzocaine, dibucaine. Articaine can be used for dental surgery. By the use of this topical local anesthetics, the risk of toxicity is low. The second route of action is the route. Most commonly, these local anesthetics, they are given by injection. So they are locally infiltrated into the skin. And the action of their anesthetic action is only localized to the area of injection. Their duration of action can be prolonged with a co-administration of alpha agonist sympathomimetic drug I've already discussed with the addition of epinephrine. With the addition of epinephrine, the duration of action is prolonged, the quality of block is better, and there is less chances of toxicity of the drug. Now, what is the difference between local anesthesia and regional anesthesia? Usually, local anesthesia is applied to a small part of the body where the local anesthetic is injected or are given by topical application. So it is a discrete area of the body which is anesthetized. Or usually the minor surgical procedures uh, carry out under this local anesthesia. But when these local anesthetics are injected into intrathecal or epidural space in large doses, whole limb is paralyzed. Yeah, the dermatomes beyond that level of spinal cord are anesthetized. So the major surgeries can be carried out with regional anesthesia. Toxicity is very important, and MCQs could be asked about the toxicity of local anesthetics. Almost all local anesthetic can produce CNS toxicity, and there is a spectrum of symptoms which may develop with CNS toxicity. Toxicity usually develop if the large dose of local anesthetics are used. So there is a maximum toxic dose calculated for each local anesthetics. And usually for clinical practice, we are using that local anesthetic under that maximum toxic dose. We do not exceed that dose. But there is always a risk of unintentional injection given intravascularly. So if local anesthetic is given intravascular unintentionally, the toxicity may appear. And the CNS symptoms are more common. So there is a spectrum of symptoms. The patient may have lightheadedness, mild sedation. He may have auditory disturbances, visual disturbances, restlessness. And the first symptom appear is, you should remember, this is circumoral numbness or perioral numbness and tongue paresthesias. If you have given unintentional intravascular injection of local anesthetic like lidocaine or the bupivacaine, the first of all the patient complains कि उसमें उसके होंठ जो है वो सुन्न हो रहे हैं या उसकी जुबान जो है वो सुन्न हो रही है, and he may have a metallic taste as well. But if the toxicity is more, or especially the higher dose has been given, the patient may have nystagmus and muscular twitching or seizures, and these seizures may become very troublesome, chronic seizures. And after that, there is CNS depression, and the patient may have sensory and cardiac arrest. The management of these CNS symptoms are symptomatic, and usually these tonic-clonic convulsions, they are very troublesome. So these are controlled with either the benzodiazepines, midazolam, or diazepam. They can be used as a pre-medication to prevent these tonic-clonic seizures. But if these seizures develop, you may use diazepam or midazolam. But if they are not controlled, then you can move further. You can use a barbiturate like thiopentol. If they are not controlled, then a muscle relaxant may be given. The patient has to be intubated and put on ventilator. Besides CNS effects, the cardiovascular system is the other system which are more susceptible to local anesthetic toxicity. And again, there is, because these local anesthetics, they depress myocardium. They depress the automaticity of the conduction system of heart. So there may be bradycardia, heart blocks, and all local anesthetics, they cause vasodilatation except cocaine, This is an MCQ. So there is vasodilatation, there is bradycardia, heart blocks, hypertension, and other dysrhythmias, and the cardiac arrest may happen. All these hypertension, bradycardia, and heart blocks, they lead to cardiac arrest, and the treatment is again symptomatic and supportive. Bupivacaine is more cardiotoxic than other long-acting local anesthetics, and the bupivacaine has two isomers. Uh, the levobupivacaine is less toxic than dextrobupivacaine, and so the dose of bupivacaine should be uh, calculated very carefully. And whenever you are giving bupivacaine, locally infiltrated or intrathecally or in epidural space, always make sure by plunging the syringe that there is no blood coming into the syringe. If there is a blood tinge, you shouldn't inject the drug because it may go into some blood vessel and cause serious cardiac toxicity, leading to cardiac arrest. These pregnant patients, they are more susceptible to this cardiac toxicity of local anesthetics. So we come to the cocaine. Cocaine is the first local anesthetic ever used in human history. In 1884, by an ophthalmologist for an eye surgery. So cocaine has can be used as a topical local anesthetic, and it has a unique uh, intrinsic sympathomimetic activity which cause vasoconstriction. So there is less blood loss, especially the nasal surgery or the pharyngeal surgery. But the cocaine is a drug of abuse. It is usually sniffed, and due to vasoconstriction of the mucous membrane, it damages the mucous membrane of nasal mucosa or may cause injury to the nasal septum. It may also cause, because it's a vasoconstrictor, it may cause a severe hypertension and may lead to CVAs. Prilocaine is an amide local anesthetic. When this drug is used in large doses, uh, there is a metabolite, toluidine, which may cause methemoglobinemia. And if it is severe, the patient may be cyanosed and it has to be treated. The treatment is IV methylene blue or ascorbic acid, which oxidize methemoglobin back to hemoglobin. Allergic reactions, though rare, but may happen. And they are more common with ester types because the ester local anesthetics, they are metabolized to PABA, para-aminobenzoic acid, which may cause allergy. The amide types, like the commonly used our local anesthetic like lidocaine, bupivacaine, ropivacaine, they don't metabolize to PABA, and the allergic reactions are extremely rare, so they can be used safely. At the end, we just look at the clinical classification of local anesthetic and how they are used. First of all, the topical anesthesia. We have discussed is topical anesthesia that they may be applied to the skin or the mucous membranes for oral surgery, nasal surgery, urethral surgery, or they can be used for, in sports injuries for minor surgical procedures. Infiltration anesthesia, injection, the drug is infiltrated by injection into the dermis for a discrete part of the body. So the minor surgical procedures like stitching and abscess draining or the lipoma, ganglion removal, or the mole removal, these minor surgical procedures can be safely conducted by infiltration anesthesia. These local anesthetics can be given intravenously, though there is a risk of CNS cardiac toxicity, but they can be used. And it is interesting that the first IV regional anesthesia was given about 120 years ago in 1898. In 1898, uh, by a doctor, August Bayer. And this Bayer block is being still used in modern practice. And the surgery of upper limb can be carried out under Bayer block. A tourniquet is applied proximally on the upper limb, and then intravenous local anesthetic is injected into the limb, and the limb is anesthetized, and so the surgery can be carried out. Even a major procedure can be done with IV regional anesthesia in limbs. Then there are field blocks, and the field blocks are usually given for post-operative analgesia. The drug is being injected into the different body planes, and the nerves are being anesthetized, and the post-operative analgesia is very good with field blocks. Nerve blocks, this is the modern practice, and our young anesthetists, they are very enthusiastic and they are very interested in nerve blocks with the help of ultrasound. With the help of ultrasound, the nerve bundles and the nerves are being located, and the injection is given around that nerve. So that nerve is blocked. When the nerve is blocked, there is no sensory transmission. So the brachial plexus can be blocked like this. So there is a lumbar block, there is a sciatic nerve block, and there is paravertebral blocks, and so on. So ultrasound guided nerve blocks are very effective, especially in old patients with compromised cardiac function, with compromised renal function. So these nerve blocks are being, for the last 1 or 2 decades, they are in practice. Epidural anesthesia is also very popular. And in epidural anesthesia, the local anesthetic drug is injected into the epidural space outside the dura mater. There is a potential space called epidural space, and a large amount of drug is injected in that epidural space, and a catheter is placed into the epidural space. And by placing that catheter, you can repeat the doses. So you can prolong the anesthesia as much as you want, and uh, and you replace that catheter in epidural space for next 2-3 days after the surgery. So there is a very good post-operative pain control with epidural anesthesia. So epidural anesthesia can be an adjunct with general anesthesia, especially when there is a major surgery uh, regarding cardiothoracic surgeries and the laparotomies, which are very painful when the anesthetic effect is gone. The patient is came out from general anesthesia and there is anesthetic effect has been wave off. It's very painful, thoracic surgery and the laparotomies, because with every breath, patient feels pain. So epidural catheter is placed before giving general anesthesia or after giving general anesthesia, and the catheter uh, being, being maintained in epidural space for next 3-4 days by giving epidural analgesia. Similarly, the painless delivery, you can give epidural anesthesia. And the last is spinal anesthesia, very commonly used in nowadays. And in spinal anesthesia, you can have laparotomies, lower abdominal surgeries, perineal surgeries, and lower limb surgeries like amputations and all sort of orthopedic surgeries can be performed under spinal anesthesia. And it's very safe and it's very convenient. So the last about 20 to 25 years, now the trend has been changing from general anesthesia to local anesthesia or regional anesthesia, because these regional and local anesthesia are much safer than general anesthesia. In general anesthesia, you have paralyzed the skeletal muscles, including the respiratory muscles, so there is no breathing. The patient has been put on a ventilator. So the patient जो है वो या तो उसमें वो मशीन के रहमो करम पे है या फिर जो एनेस्थेटिस्ट खड़ा है उसके रहमो करम पे होता है. तो अब यही है कि जहां पर लोकल एनेस्थेटिक्स यूज किया जा सकता है तो लोकल एनेस्थीसिया जो है वो दिया जाए अगर कोई कॉन्ट्राइंडिकेशन ना हो. They are much safer, they are very, very effective and beneficial drugs. A few interesting words. I have mentioned earlier that cocaine was the first local anesthetic, which is used in 1884 for an eye surgery by an ophthalmologist. And then August Bayer, he used cocaine for spinal anesthesia. First spinal anesthesia was given.
Sorry to interrupt you. Just
First spinal, first spinal anesthesia was given in 1898, and lidocaine, most commonly used drug in our operation theaters, it is being used in 1947 when Pakistan came into being. So can you remember from 1947 we have been using lidocaine. So thank you very much for listening me patiently, and I wish you all best of luck. Thank you very much.